shifting gears, so we've induced the patient. Hopefully, we've had them achieve a good response or clearly no visible disease. We'll get around to the concept of minimal residual disease after we talk about the next topic, which is really consolidation. So at the current time, what would you view, Elias, as really kind of our standard consolidation or some of the thought processes in terms of consolidation choices?
Okay. Well, Ruben, you induce somebody, you induce a CR. No, CR, you mentioned when I talk about MRD, but CR doesn't mean cure.
Sure.
Doesn't mean the leukemia is gone.
Yeah.
Doesn't mean nothing is happening. Although in the US, the tendency not to give a lot of consolidation.
Yeah.
So at my institution, we give at least 4 courses of high-dose RSE consolidation. And then based on your prognostic factor from the beginning, if you have somebody responding with bad features, today the standard of care is to go for transplantation. Although I think the transplant, the way we do it, it's not the best way. We have to be more innovative in kind of give conditioning and transplant and go for maintenance strategy post-transplantation, implement the new treatment we have into the conditioning and post-transplantation. So somebody in a good response and having no minimal disease and good features like CBF, we go for consolidation chemotherapy. Somebody who's young, who's responding but had bad features, consolidation 1 or 2 courses to get them for transplantation, go for transplantation. Now, elderly people who are not fit for, you need to keep them on therapy, and we don't know for how long. You give them decitabine or AZA for how long? For a year, for 6 years, ad vitam aeternum. Today, the strategy is to give them treatment all along. You mentioned at the beginning the FLT3 inhibitors, and these compounds, you give them only for induction, or does it matter to give it continuously? I think it does. At the beginning, in our treatment, we did it a few days at the beginning and then consolidation. But now we're noticing they may benefit more from continuous exposure, provided you can give the drug all along, induction, consolidation, and maybe maintenance treatment as well.
So our approach for the consolidation has been looking, as you mentioned, looking at allogeneic stem cell transplant versus high-dose chemotherapy. Now, even if you have an allogeneic stem cell transplant ready, you could argue that somebody who's complete remission can proceed to allogeneic stem cell transplant. Most of the time in real life, that's not the scenario we see. First, patients are recovering from, they need to wait. Transplant usually is not ready in 2 to 3 months. So we end doing few cycles of chemotherapy to take them to transplant. I think the other thing that's evolving now is really that if you are deciding just to do intensive high-dose RSE, for example, first is how many cycles you need. That's never really has been established. In the good risk, I think everybody follows the CLGB study with 4 cycles. But the other thing also is evolving is what is the optimal dose of the high-dose RSE. We typically done the high dose 3 grams, but there are studies coming suggesting that you really need that only in patients with good risk, while you could do well with a moderate dose or intermediate dose of RSE in the group that doesn't have the good risk cytogenetics.
So now in this process, there clearly is interest in a variety of areas in this concept of MRD, and perhaps most relevant in this group of patients of which we've completed consolidation. We're hopeful that they have very, very minimal disease, and we're observing them. Because obviously we're selecting out, as we've discussed, many patients to move on to transplant based on their risk. Where do you think MRD stands, particularly in the setting of AML? Is this, how relevant is this concept yet for us?
I'd remind you that we typically look for minimal residual disease by the means that we have available. So we do a bone marrow biopsy after the first course of induction to see if there's any disease remaining. And if there is, we often treat again to go for that CR. Now, that's a relatively crude technique that just looks for the morphologic presence or flow presence of these cells. But we can go much deeper now that we have better flow cytometry techniques and better genetic techniques to try to find those really small subclones that we can't see under the microscope. Now, it's worked extremely well in disorders where you know what the mutation that caused the disorder is, and you can look for that. So APL is a great example where minimal residual disease monitoring makes a big difference. You know which patients you have to treat more intensively if you find that there is residual disease after that first course of therapy. Now, in things like standard non-APL AML with normal cytogenetics, you can't look at karyotype to look for minimal residual disease, and flow cytometric techniques have been useful, but the mutation testing may actually be even more sensitive. There was a very interesting paper that was recently published in JAMA where they looked for the presence of mutations at day 30 after treatment and found that patients that still had mutations at a low level were certainly at increased risk of relapse, and it was a substantial difference. So while this hasn't yet entered, I think, standard of care for normal cytogenetic risk AML, it's something that will probably move rapidly and begin to reach clinical practice.
Very helpful. So as